Okay, welcome everyone. Thank you for your time, your giving, and your decades of loyalty. This is a very targeted group of individuals who've been supporting Albuquerque Healthcare for the Homeless for a decade or more. So you should be proud, you should feel proud. Everything that is accomplished is because of your investments, and the changes we make every day are because of you. I am Anita Cordova. I'm the Chief Advancement Officer, celebrating my 15th year with the organization this year. Also on the call, we have Autumn Porter-Watkins, who's our Development Associate. We have Jeremy Yazzie, who is our Communications Associate. And she just went off camera, but Carol Weldon is our Executive Assistant. And we are many of the people you will see or talk to as you have questions about development or communications. So never hesitate to reach out to us. Jeremy and Autumn will be putting contact information in the chat for your information. So before we go to Jenny, I want to learn a little bit about those of you in the audience right now. Will you raise your physical or virtual hand, whatever you're comfortable with, at one of the following options that keep you engaged with us year after year? One, you have a personal connection with homelessness. You've known someone who's experienced homelessness, you've had experience with homelessness, something like that. Want to raise your hands, virtual or otherwise? The second option, if you're a former, current staff, board member, volunteer, or partner, so you've experienced our work and in some way or another. So we have 4 hands on that one. 5. And then the last option would be you believe in a just world. How many of you? All right, I like it. We're with the right group of people today. Thank you for that. So with that, I'm going to go on and introduce our guest speaker, which is Jennifer Metzler, Albuquerque Healthcare for the Homeless's Chief Executive Officer. I'm honored to have this opportunity to introduce her. She is our esteemed Chief Executive Officer. She is a bright spot in the organization indeed. Our favorite stories about Jenny are how she applied and applied and applied to work for Albuquerque Healthcare for the Homeless. And until she applied for a development position and found the right spot, she just kept applying. And so we are so grateful for her persistence. Now, 26 years later, she inspires our outreach focus with her stories and experience of international fieldwork with women and children in Latin America. She's made our favorite celebration of the year, Human Rights Day, and she engages clients and staff by moving nimbly throughout the campus and entering and exiting through all doors to talk to as many people as she can. She regularly takes staff to lunch or coffee and/or entertains us with walking meetings around the neighborhood. She engages us, keeps us in the loop, and she is here today to do just that for you. Without further ado, I turn it over to Jennifer Metzler, Albuquerque Healthcare for the Homeless's Chief Executive Officer.
Thanks, Anita, and thanks to the team for putting this together. And thank you to all of you. This is such a great size group, and we have very little time, and this is kind of our inaugural attempt at this format, so we're glad that you're helping us test it. This was inspired by particularly something we had in mind, but particularly kind of finding the way for it to be to engage in dialogue around our work with people who support and care about our work during the pandemic. And I can think of multiple times where I or others of our staff were invited to an iced tea distance in someone's backyard, in a neighborhood here in town, just to talk about issues, talk about what our role was, how our staff were doing, how our clients were doing during the pandemic. So we want to replicate that a little bit, and I'm glad to see that some people have their tea or their food or whatever. We also wanted to provide a little bit of content for you to think about and respond to. I hope everyone got the links. I hope they were abbreviated and short and accessible. The things we want to focus on just content-wise, and I'm not going to go into a review and detail of the materials that you were sent, but number one, we get asked a lot about our focus and how we make decisions in the organization. That is all about our strategy and our roadmaps, which we internalize and I think live well. And then also the pandemic, which we're still in, and what our role was there and how we did it. So I'm just going to talk a little bit about those. You got the material from our board approved strategy refresh of November 2020. And I want to talk a little bit about how that came to be, how we got those priorities, and then hear your thoughts about that document rather than going over the content. I will acknowledge that Ari Herring and Laura Crow, both previous, and Patricia Reardon, previous president of our board of directors, but Laura and Ari are on our board of directors. We're part of the strategic prioritization process. And what we did in the middle of the pandemic, or I don't know where the middle mark is on the pandemic, but last year, as planned, although we were in the middle of COVID and COVID response, we felt it was really important to pause and say, are our strategies still good? Are they still viable? Do they make sense? And what we ended up doing was really affirming our model, affirming our mission, affirming our role in the community, and further refining that, and energizing and galvanizing all of us to go forward, because this isn't over, this isn't done, and we have a place in it. So we get up and come to work every day, and having that roadmap is really important. We're very strategically oriented in the organization. We have learned in recent years how much tenacity and pure commitment and intent can get some strategy done, but it's better if we resource that. So we have learned about the strategic business plan that really bolsters, provides a foundation for resourcing our ambitious strategies. So what you saw in that document was sort of just an update. We call it a refresh of our strategy, because in 2016, we worked on and approved a 2017 to 2023 strategic business plan that was to support a strategy roadmap that had 3 strategic priorities beginning in 2017 to do more outreach, really get back to the hallmark of our niche and our history, and get out from our 4 walls and get out where people who maybe couldn't get to us could get services, or even if they could get to us, where we were eliminating that barrier and that stressor of having to get to our beautiful campus here at First and Mountain. You're welcome to visit us here anytime when you feel safe. We're all here on campus again and doing tours. But so outreach to reach more people and new people who weren't getting care like ours. We also said that we wanted to do high quality work, have a high quality workforce. And we wanted to share this model that we've been working on for 30 plus years, 35, 36 years, that is really a good model of integrated healthcare that addresses the structural underlying root causes of homelessness and poverty through a healthcare lens. And so when we talk about amplifying what we do, we want the whole world to hear what we do and how we do it. And hopefully we can shape that so that systems that are not responsive to people, structures that are not helpful to people who are vulnerable to homelessness, can better serve them, and we can both end and prevent homelessness. We took that strategy roadmap from 2017, and in 2020, at a midpoint of a 6-year plan, the board, staff, management, people with lived experience on our board of directors, and our frontline staff, not only management, our frontline staff, went through a process with a facilitator and did a refresh on that plan. So the 6 strategic initiatives are our refinement of our strategic priorities. Those are sort of broad stroke efforts and large organizational goals that we're making great strides on. And the operating frameworks were something new for us. The 5 operating frameworks were how we're capturing how we do what we do. What are sort of the values and the philosophy of care and the most important mindsets that we need to operationalize in order to really advance strategy and have that kind of impact in the community. So that's how we got to the document that's in front of you. I know I need to moderate and facilitate any questions or impressions you have of that, but I'm going to stop talking so that we have more time to talk in this half hour.
Thank you, Jenny. Yes, if anyone has questions, put them in chat while Jenny is talking, or raise your hands, and we'll just do this very fluidly. We're also trying to we didn't know how big the audience would be, but hoping to engage folks. So if you believe that homelessness can be solved, please type 1 in the chat and then ask any questions you might have, or we will move on to the next agenda item.
Nothing for now. Anything from the chat team that I need to be paying attention to?
Nothing in the chat yet, Jenny.
Okay, thanks. So I want to talk about our pandemic response. And this is so full of maybe apparent contradictions that make total sense to people as we think about it. We're often in that, rather than being in thinking about things as either or, we're thinking about where the either and the or are happening together and trying to make it things and but. And an example of that is crisis response and strategy, that we need to do both. We have to always be thinking about both. And that's how we remain really viable and relevant in the community and reaching people who need what we have to offer and the resources that we have. So probably within the first 10 days of March 2020, as all of our eyes were widely opened, we were able to deploy and redeploy our teams. So we needed, for example, to close down aspects of, because of public health orders, our dental clinic. So we redeployed the teams there to other areas, public health advice, protocols, and other shelters, being a resource on how they can isolate. They didn't have public health practices, infectious disease control in place. So we became a resource to our peers. We redeployed a resource center and Art Street community space, unfortunately, were congregate sites and programs that needed to be temporarily put on hold in terms of use of the space, but we redeployed the teams to outreach. We ended up quickly moving about 50 or 60, a little more than half of our teams to remote work in their homes. The technology and the IT department were ready and they did it, and it was a heavy lift, and just even how you supervise that quickly. It's one thing to plan to have more remote staff, but how to do that quickly. And we did that not only to isolate people from the direct service work, but so that we would have a healthy bench as people, we knew people were going to begin to be exposed to COVID, and we wanted with our workforce to have a healthy bench. So we did that. Senior management for the most part, and management, I was, for example, on campus at our Central Health campus 50% of the time, sometimes on street outreach, sometimes in the courtyard, sometimes in my office with a mask and hand sanitizer. We were all really practicing being very, very careful, using Zoom quite a bit. And then we had the rest of our folks deployed in integrated teams to the shelters, to encampments, to the streets. We really, really, really intensified. We had planned to in our strategy roadmap, but really intensified our street medicine and backpack medicine, integrated teams, harm reduction, even dental outreach to people who are in the streets and the shelters. We did end up having to rotate some of that bench. I can say to date, to my knowledge, though I haven't talked to our chief clinical officer today, we have had one COVID positive employee case that was workplace exposure, to our knowledge, as best we're tracking. And we had teams of people, we were doing, our outreach teams were a central dispatch for the city, the emergency operations centers, the county, our other shelter and homeless services peers, and First Nations, our peer that also has a team doing street medicine, backpack medicine, in integrated teams out on outreach. And we were the central dispatch, so that when another outreach team or a shelter called and said, we think we have someone who's exhibiting symptoms, can we get them tested and screened, we could deploy either our medical providers with support. Almost, I was on a roving street outreach where we got a call from Street Save. They said, we're 4 blocks away on East Central one Wednesday afternoon. I was with the doc, a harm reduction outreach, and a medical assistant. And they said, there's someone here in this parking lot on the corner who's really sick and symptomatic. Can you get down here? And we were able to get down there. I was with the doctor in the van. We were there in 10 minutes. They were able to assess, and then we were able to test, and we were able to do follow-up with that person. So when I would talk to our teams, because communication was so important about the pandemic, and say, I understand this is hard. I know your families are scared. I know some of this is new. This is what we're doing. Our work is relevant. The comment I most got was, hey, we're built for this. So while on the one hand, I had even the Secretary Holland, now Congresswoman Holland, called from the floor on a Recovery Act vote, stepped outside with her staff and checked in with health centers and called me and said, Jenny, how are you doing? How are your teams? And I said, we're great. And it was such a strange thing to say in the middle of all of it. So this was about June or July of 2020, and then or a little bit later. And I said, let me explain that, Congresswoman. We are relevant. We know what we're doing. We have meaningful work. We kept everyone employed. We did not close our doors. We did not furlough anyone. We are financially sound, and we're going to continue to do this work. And it's not denial. It's not running ourselves into the ground. It's that we know what we can do for the unsheltered and unhoused population in Albuquerque. And we've done that very collaboratively on continued daily huddles with public and private entities and all of our partners. And we've actually increased our outreach sites at shelters, meal sites, hotels, that isolation and quarantine. We're doing rounding. We're still doing all that. It's still all going on. And those of you who are connected to the healthcare system know that. There's one thing that we did in addition to those that I just want to highlight, because it's been featured in the media. It really was a really cool thing our outreach teams came up with. There were people who were not willing to go into isolation and quarantine, who were unsheltered and sleeping rough, and we were reaching them. And we wanted them to still be as safe as they could be. And so we were advising them about how to sleep in an encampment, rough and completely unsheltered. We know that those who are sleeping unsheltered are much more at risk for violent victimization, 25 times more, and for death and severe illness. And so we really wanted to reach them. And so our teams put together what we call isolation backpacks. And they had thermal blankets, and they had hand warmers, and they had thermometers, and they had disinfectant, and they had socks, and they had snacks, and they had oral rehydration therapy. It was the coolest thing. We got funding for it. Some of you probably supported it. And we have given out hundreds and hundreds of those and continue to. And they're well appreciated, and they're just uniquely suited to people who, for whatever reason, will not, did not, and haven't come in.
Thank you, Jenny. There's no questions in the chat yet, but I do know from many conversations with donors and a recent donor survey we put out that many of our donors are interested in knowing a little bit more about the benefit connections we did related to COVID, and also what we're doing around vaccinations. Can you tell us a little more about that, please?
I sure can. So our general approach to what we called the public health emergency response for the unhoused population around the pandemic was that we leveraged our niche and our resources and what we could do to a greater public health system that was pulled together as part of crisis and emergency response. So we were not saying we're going to solely take care of every single aspect of this for the entire homeless population in Albuquerque. We are very collaborative. We're wired that way. We know that we cannot be an empire, no matter how big we get, and do all things for all people. So collaboration was already in place. We were called upon to be a resource, and we were very clear about how far into that we went. At the isolation and quarantine hotels, there were, my favorite story is 14 firefighters, forest firefighters from California. Should our docs be rounding with them when there were other docs there from other systems and public health and the Medical Reserve Corps of the state? Should they be the ones treating them in the isolation and quarantine hotels for COVID? And we had to pull back. We said, you know, we really need to allocate our resources to the unhoused population, because if they're not in isolation, we need to be out on the streets for them. So we were always being very clear about our strategy. Similarly with testing and now vaccines, that we are not doing drive-through testing for the general population. There are health centers, federally qualified health centers, that have done that serve a more general population, and they really stood up. Even some healthcare for the homeless partners, you know, doing 400 tests a day in a garage, in their parking garage. That's not our configuration here in our community with the resources and partners that we have. So we really are sort of supplemental, but integral, and we're very clear in our niche. So for vaccine and testing, we're doing it here, we're doing it in the streets. We're still inducing Suboxone in the streets. We're really doing what we do and taking it wherever people are who need us, in coordination with the other systems. So we're not central, because I will say the state of New Mexico and the Department of Health have really prioritized the unhoused population and made sure that resources on the ground got to them. As far as benefits and some of the eviction prevention, rental assistance, some of the stimulus checks, we did clinics, we did outreach, we worked with partners, we were in parking lots, we were making sure, you know, some people, if it's going into your account based on your IRS tax filings every year and you don't file taxes, then where's your stimulus check going to go? So there were mechanisms working, again, with the city and the county and the Center on Law and Poverty and some others, where we were able to really, what we can do is find people and engage them, so that just knowing what to do, how to do, and who can help you get it done. Because what we have really learned during this pandemic, and we knew before, but we were much more adamant, is that every time someone is enrolled in whatever public benefit, a housing voucher, Medicaid, Medicare, SNAP or food stamps, general assistance, SSI, SSDI, that those are hard processes sometimes, but that is cash resource for someone to end their homelessness and prevent future homelessness. It is one of the highest impact things that we can do. And these emergency funds were really important to get to people. Our psych nurse practitioner, we asked the congressional delegation wanted to know what people were doing with those dollars. And so we asked our providers, and the one that was just most memorable for me is that our psych nurse provider said, my clients are updating their phones plans so that they can access telehealth and stay in touch with me. They're getting their cars repaired so that once they can be social and more engaged, because they're feeling very isolated, they'll be able to get to the places they need to go to get that support. People did very smart things when you give them money. Every dollar you give someone reduces their poverty. And this idea that people don't know what to do or how to manage it or frivolous, that was not our experience at all. And there are now some studies coming out substantiating that. So we now have a whole public benefits initiative that is organization-wide. How many people can we have? Every single person we should be helping to enroll. And we want to know the dollar amount, the exact dollar amount of cumulatively, hopefully by the end of this year or next, we'll have a big marquee and we'll be able to say on the banner, we assisted this many people in getting more cash resources to address their homelessness and end it. And it is this big dollar amount. It's going to be a lot of zeros. It's one of the highest impact things we can do.
Very inspiring. Thank you. Matt wants to know how our collaboration is going with First Nations. And then before you answer that, Stephen Glass has a question. And after she answers that, I invite you to come off mute and ask yours, Stephen. It's a great question. Jenny, how's collaboration with First Nations going?
Yeah, we've always had a good collaboration with First Nations. For those of you who don't know, they are a sister federally qualified health center that also has a dedicated a designation to serve the population that is experiencing homelessness. We're 100% healthcare for the homeless. They have a portion. And so we really do collaborate well together. I think this has really solidified and even more institutionalized that collaboration. The dispatch, we were the central dispatch. We worked with their outreach team and our outreach team, who best should cover this, when and how. We're working on a medical respite initiative for people who don't need to be hospitalized or need to be released from hospitals and have nowhere to go because they're unhoused. And so they're working with us on that to continue to help staff it for that higher level acuity. We're coordinating street outreach with them. They do training for us because they're really have a long, deep history of being of and for and serving Indigenous communities. And, you know, we can really benefit from their training and what they can teach us on that. I talk regularly with Linda Sunstone, the CEO there, longtime partner, and we talk about strategic things with service area coordination with the primary care association. It's really many levels deep in our organization, and it's, you know, really from that. It's right now we think everything we think about, we think person to impact and policy, person to structure. Where can we influence and how can we be consistent there, and how do we, like, all hands on deck to do their role in that with our partners. And so it's really strengthened that and clarified, I think, how we can work together for higher impact. Does that answer your question, Matt?
It's a great question, Matt, and indeed, great response. We can't do what we do without all of our partners. Very important to ending homelessness. Stephen, would you like to ask your question? I'm also happy to ask it for you, whatever you're comfortable with.
Well, I unmuted, so I may as well just go ahead and express it. I have seen recently in the journal the county tiny home, the 30 tiny homes that were built specifically to try to address unhoused population is struggling. They can't seem to recruit and keep unhoused individuals protected there. And I'm wondering if with the obvious extremely efficient management that you have at AHCH or at Albuquerque Healthcare for the Homeless, if maybe there's an opportunity to collaborate and make better use of that fairly groundbreaking facility in my mind. You know, it seems like it's really a step in the right direction, but for whatever reason, it's just not happening.
Yeah. So we have been there since it was conceptualized. And so what I'll say is tiny home villages are, is this not the question of the day? I'm so glad you brought it up. I think what tiny homes villages illuminate are the big question right now that elected officials, even those who are biggest supporters of housing and addressing homelessness, are saying housing is too expensive to build and it takes too long. So we need other solutions. As an organization, and I feel very, very deeply about this, I'm not willing to relegate any of our neighbors and community members to anything less than safe, affordable, reliable, permanent housing with the support that they need. Now, we still need shelters and we still need other places. So I think the tiny homes is an attempt to be really creative about that and responsive to that. And so we've been talking with Commissioner O'Malley at the time, City Councilor Gibson, when they were first conceiving this, some of the grassroots advocates who worked with the county and were really involved in that from the moment it was a pip of an idea. And we've been talking through, like, we can't call this permanent housing, but we will definitely be engaged, and we will definitely do outreach there. And it's not going to help everyone. Not everyone's going to opt for the model. I think what they're learning is it's not so much that there are not people to be recruited. I think that they're realizing that their threshold and their eligibility requirements and their program participation requirements attached to that type of housing are too stringent. And I think, you know, we had concerns about that from the beginning, honestly, but we don't always agree with our partners. It's always a very iterative, toggling process, but we remain engaged with people that we disagree with, you know, except in the case where they're just horrible and abusive and we can't philosophically do that. And that happens, unfortunately, but it is, you know, they're testing this idea. I think that there is some willingness to reconsider. We'll certainly remain engaged. We'll serve the people there. We can refer people there. But I think that and our organization has often been one, we don't ban people for life. We might ask people to leave services for a while if it's just not safe for them or the campus, or if they're just really, we have various reasons that our teams and clinicians come together and will consider just separating someone for a while. And sometimes clients separate themselves for a while, but we don't ban people for life. We don't have this, we are really very harm reduction person focused team approach where we try to do everything that we can to keep people engaged in services. And if they have to leave, that they come back from services. So many of the people that we're serving are ones that can't meet those criteria in other settings and with other organizations. And I think this is becoming one example of that. But I do know the people who founded it, who have their hands on it, are managing it. And I think they are considering what hasn't been working and reevaluating that. That's my sense. So we work very closely with the county and the city every day. I hope that answers.
Thank you.
But this is a really great, this is something for, you know, the community to look at. You know, how was this going to be a quick solution? How was it going to be a really cost-effective solution? And how has this turned out? Not to blame anyone, but to consider it so that we understand the problem best, understand the responses that are most effective, monitor them, are transparent and honest about it, so that we as a community can have the impact we have to have. You know, people create these, we just heard this from a keynote speaker. We say it all the time. Matt Vega probably said it to me first. You know, historically, our great leaders have said we create these problems. So it's about the choices and priorities, about resource allocation, about the ways we approach things, and how we come together to be able, we can change them. We can address homelessness. So this is part of that learning process.
Thank you.
Wonderful. Well, we are happy to stay on another 5 or 10 minutes with you all if you have any top of mind questions or other discussions you want to have. That's what we're here for today. I do